Well, hello, and welcome to another in our series of brief lectures on topics within GI pathology. Today we're going to be talking about tumors of the large bowel, specifically some of the cancers and their consequences. Our objectives today are to discuss the various types of colon cancer subtypes and some of the treatment implications, as well as testing implications in those situations, particularly those testing situations where molecular testing may guide treatment. We'll review some of the newer biomarkers and talk about their use and misuse to some degree. In connection with that, it's important to note that the College of American Pathologists has a specific template for the reporting of colorectal cancer biomarkers. This is effective as of 2014 and fairly comprehensive, including the more common ones and some of the less commonly reported ones. Of course, we continue to use the standard protocol for surgical examination. That likewise was recently updated in 2020. What is important, though, is to realize that both excisional polypectomy and local disc excision specimens can and should be reported using this tool. Well, unfortunately, life isn't fair when it comes to colorectal cancer. There is an inordinately disparate distribution of incidence and, of course, mortality along with that throughout the world. And you can see the vast differences between, say, Australia versus Western Africa. Now, ironically, of course, here it doesn't always pay to be born well off in a Western and more developed country, because your incidence of colorectal cancer is going to be higher, certainly no doubt related to diet, lifestyle, and other factors. Well, that aside, wherever you are, demographics will matter to some degree, and this data summarizes in a numeric manner how being an African American is a disadvantage, both with respect to incidence and mortality in terms of colorectal cancers. Likewise, you can see various increased incidences in other specific ethnic demographic populations as well. Beyond just the genetic and ethnic background, there are a number of personal risk factors associated with colorectal cancer, which are important to note. First of all, physical activity does pay off in this respect. Reducing relative risk, or if you lack that activity, increasing your relative risk. Similarly, red meat, obesity, smoking, all of those are increasing risk factors, whereas a more plant-based diet significantly diminishes your risk of colorectal carcinomas. So let's talk a little bit about the kinds of specimens that we receive. With regard to management of these, fixation and dissection are really vital to being able to properly demonstrate the critical factors for staging and prognosis. We also need to be able to demonstrate microscopically the important findings that will govern treatment and prognosis. And then sometimes the purposes in gross dissection is also to supply samples for appropriate ancillary studies, either now or potentially in the future. So one area where this is particularly important is in lower colonic specimens. Here we see a low anterior resection specimen, including a portion of the sigmoid colon up here proximally. Here we see the mesorectal envelope with a nice demonstration of the peritoneal reflection right here. And we can see that by and large, this mesorectal envelope is complete. And we have tried to provide inking to demonstrate that. Now, this is not always possible, but it's certainly ideal to be able to demonstrate that. And that allows you, once you have performed proper fixation, to then demonstrate the nature and relationships of that tumor to the margin. And this intact fixation method is important if you're uncertain as to the precise location of the tumor or its relationships to margins. You don't want to be slicing through this in a fresh state and potentially disturbing or interfering with your ability to confidently state that the tumor does not involve the margin. So, for example, here, fixation, inking, and nice sectioning allows you to see that, at least grossly, you have a close but probably free, clear margin here at the mesorectal envelope. Identifying the pre-existing polyp can be of an importance in some circumstances. So seeing that there's an associated polyp can be helpful. Tumors can be both fungating or ulcerating. Here's an example of the more polypoid type of lesion without the presence of ulceration and rolled margins, as with a more fungating type of lesion. In certain other situations, there can be background disease such as ulcerative colitis. Here you see a very atrophic, scarred or ulcerated area with the presence of a tumor arising in the setting of ulcerative colitis. Now, the WHO classification has not changed markedly over time, but there have been a few recent modifications. First off, the poorly cohesive and signet ring cell carcinomas have been lumped together, becoming a single category. We have the introduction or the preservation of the term serrated adenocarcinoma, as well as adenoma-like adenocarcinomas. Additionally, micropapillary adenocarcinomas, though uncommon, are now recognized as the histologic type. Neuroendocrine carcinomas are divided into large and small cell type, and we have recognized a grade 3 well-differentiated neuroendocrine tumor. And finally, the previously mixed adeno-neuroendocrine carcinoma has been altered slightly to be a more generic term that allows the presence of neuroendocrine and virtually any non-neuroendocrine neoplasm, and thus it has a new acronym, MINEN, in this case. So here's a typical colorectal adenocarcinoma. We recognize it for the presence of necrosis, the tall, dark, and dirty cells with the dirty necrosis, and irregular branching glands and so forth. This is another example showing you the kind of typical dirty necrosis, a lot of karyorectic debris within the lumen, and the variable glandular shapes, cribriforms formation, and so forth. Mucinous adenocarcinoma, also not usually a difficult one to identify. It's defined as mucinous adenocarcinoma when greater than 50% of the tumor is mucinous. And of course, that's subject to sampling and some degree of observer interpretation. When lesser degrees of mucinous carcinoma are present, they should still probably be noted, as that may bear on risk of Lynch syndrome and other hereditary disorders. As we can see, many times these mucinous tumors have nests of relatively poorly differentiated cells sitting in pools of extracellular mucin. And of course, combined types can be present, as I've mentioned, such as here an area of mucinous carcinoma with a more diffuse or poorly cohesive type of carcinoma, signet ring cell features being identified. Here's a higher magnification view, and we can see that although there are some cells which have clear-cut mucin droplets with a peripherally placed nucleus, in many instances these cells are just rather poorly cohesive and do not have really identifiable mucin droplets in all instances, but we still group them together into that category. Sometimes these mucin droplets can be nicely demonstrated with a mucin stain, such as the PAS shift stain that's been used here to highlight these mucin droplets within single epithelial cells infiltrating through the muscular stroma. The category of undifferentiated carcinoma should also be mentioned, as this is a adverse prognosis type of carcinoma which lacks any evidence of differentiation. The distinction between poorly cohesive and undifferentiated carcinoma can sometimes be difficult, and hence both the types of tumor have relatively poor prognosis. But undifferentiated carcinoma should have essentially no evident glandular differentiation and no identifiable mucinous differentiation. Here we can see some degree of epithelial differentiation, but we don't see the formation of any really definitive glandular type tissue. Another important type to distinguish is medullary carcinoma. This tumor has a somewhat distinctive phenotype, often being CK7 positive and CK20 negative with diminished CDX2 activity, which is obviously quite different from usual colorectal carcinomas. Differentiating medullary carcinoma from non-glandular or undifferentiated carcinomas is very important because this is a tumor that has a more favorable outcome, but also is a tumor that has a more stringent or more highly predictive association with mismatch repair defect and potentially with Lynch syndrome. Calretinine staining can be sometimes useful in terms of differentiating these, but that's not an absolute criterion as indicated by those percentages. So here's what it looks like histologically, oftentimes associated with a fairly dense lymphoplasmacytic infiltrate. It does tend to have a very sheet-like high-grade appearance, and we can see here at higher magnification how these cells have a somewhat vesicular appearance and many tumor-infiltrating lymphocytes associated with it. A tumor that is perhaps under-recognized or perhaps under-reported because of that is serrated carcinoma. These are, by definition, tumors that arise from serrated precursors and have some sort of serrated histologic feature. Of course, tumors that are prives on the right versus those on the left may have different arms of the serrated pathway and different types of mutations involved, depending on whether they've arisen from a traditional serrated adenoma or a serrated sessile lesion with dysplasia. So here is an example at low magnification. And this may be difficult to differentiate from conventional tumors. We have some mucinous component that's readily identifiable here, but you should look for evidence of serrated architecture, the sort of serrated appearance. You may also see infoldings and tight knots of cells along with this mucinous appearance. Here we'll see a little higher magnification. And you can see there's still a degree of basal orientation of the nuclei and this sort of serrated pattern or balls of cells in association with this lesion. As I mentioned, the serrated pathway is distinctive and has two major branches. One is where the SIMP low, and we'll discuss more about these later. The more hyperplastic polyp, these would be the the left-sided lesions where KRAS mutation is more frequent. Whereas in the more proximal lesions, serrated lesions, it's usually SIMP high, and there's some sort of a BRAF mutation involved as well, with varying degrees of MSI inactivation going on with those as well. Squamous metaplasia, adenosquamous carcinomas also can occur in the colon. And here we see sort of a more benign appearing squamous mucosa, but certainly, frankly, malignant combinations can also occur. Here's an example at higher magnification. Clear cell carcinomas is not a WHO recognized type. It's an infrequently encountered variant, and these cells do have a clearing that is usually the result of glycogen rather than mucin. So should you encounter that, you can use that term, recognizing that it's an uncommon variant. In terms of grading, this is an area of some variable value. Grading is in dispute because it doesn't seem to have too much prognostic value. If we were to go to a purely two-tier system, there's some value in prognosis there. But essentially the well and moderately differentiated, the garden variety tumors, we don't seem to be able to differentiate much in terms of prognosis there. Whereas the high-grade, poorly differentiated, and undifferentiated tumors, that is a worthwhile distinction. Of course, lymph nodes are an important factor in predicting spread, and most institutions have a standard. The American College of Surgeons has recommended that there be a minimum of 12 to 13 nodes recovered to indicate adequacy of sampling. Tumor deposits also should be evaluated for and reported if present. These also can impact prognosis and have a special AJCC staging category, PN1C, when other lymph nodes are negative. Regional lymph nodes, distant lymph nodes can be classified differently. And so if you have a vessel, named vessel, superior mesenteric artery, for example, then that may classify as a more distant nodal metastasis. Here's an example of a tumor deposit. We don't see nodal architecture here, but there does seem perhaps to be evidence that this is got some vascular structure to it. So here we see a little bit of an arcing smooth muscle that may indicate a muscle wall. Here's another example. Again, no evident lymph node architecture remaining here, and here clearly a vascular structure with involved by tumor. Occasionally, you may need to do special stains, such as an elastic stain seen here, to demonstrate that the tumor is actually within a pre-existing vascular structure. And that can be a very useful tool to have in your pocket for such times. Lymphovascular invasion is an important factor as well. It's not a major prognostic indicator, but it's a relative additional risk associated with that. This can be difficult sometimes to distinguish, retraction from invasion of lymphovascular spaces, and if so, use of an endothelial marker such as CD31, CD34, or potentially D240 may be useful in identifying and confirming the presence of endolymphatic or endovascular involvement. Tumor budding has likewise been recognized as a worthwhile prognostic factor. And this is a somewhat challenging factor to implement consistently, but essentially one takes a high magnification view of the advancing edge and identifies the number of tumor cell buds, small groups such as this, within that high power field, and the count of which in a single high power field has some prognostic indication in terms of predicting nodal metastasis. Now, tumors in the rectum and so forth, occasionally the lower sigmoid, but most often in the rectum, have been found to be amenable to neoadjuvant treatment, allowing less radical surgery and increased survival and response. This is effective in downstaging the tumors and thus improving the outcomes. It's important in managing these specimens to only stage viable tumor. So not necrotic tumor, not mucin pools, not scarring. Our role in these circumstances is to accurately stage what's left, and particularly with regard to lymph nodes. Of course, after radiation, lymph nodes can be rather sparse, and so the examination to obtain a suitable number of lymph nodes is particularly challenging. So here's an example of one of the challenges we frequently meet. Here's muscularis propria, and here are pools of mucin dissecting through the muscle. However, in the absence of identifiable neoplastic cells within these pools, these are not reported as a depth of invasion by the tumor. They certainly may indicate prior tumor in those locations, but they are not used in the YPT stage modification of these lesions. Now, I mentioned some of the pathways by which colorectal carcinomas progress, and these have been grouped into several molecular categories based on data from the Tumor Genome Atlas study. One of these groupings, of a fairly large grouping of about 70 to 80%, is the chromosome instability group. This group tends to have increased acquisition of chromosomal anomalies such as aneuploidy, and to correlate perhaps with spindle cell changes as well. And this may be one of the keys in progression of the adenocarcinoma sequence, and thus this is more common in left-sided or more distal tumors. Another grouping is the microsatellite instability category. This is accounting for 10 to 15% of colorectal carcinomas, and keys in those patients who have a mismatch repair defect that results in some increased rate of mutation in their somatic sequences. Usually, this defect is caused by an epigenetic hypermethylation of the promoter region of MLH1. That's usually, not all, but this can also be seen in patients who have a germline defect in that one of those promoter genes, perhaps MLH1, sometimes PMS2, sometimes MSH2 or 6, that results in Lynch syndrome. And so detection of these patients who have the germline anomaly is of value both to them in terms of managing their treatment, but also, and perhaps most importantly, to their potentially affected relatives. There's a third grouping, which is the CpG island methylator phenotype, or the CIMP group, where there are epigenetic changes that drive a widespread methylation of many genes, including a number of tumor suppressors such as TP16, CDHI, and MLH1. And these patients tend to arise following this serrated pathway. It's really not fully understood at this point how this phenotype evolves and so forth, but it is evident in the molecular analysis of a reasonable number of colorectal cancers. So that brings us to some of the predictive markers that may be utilized in these patients, both to help predict behavior as well as to predict response to various treatments. So for example, standard chemotherapy in high-risk stage 2 disease, if these patients are MSI stable, that's favorable for them, whereas if they are unstable, this chemotherapy is unlikely to be effective. And we can see there are a number of things where that comes into play. There are other markers as well, such as thymidylate synthetase expression, epithelial growth factor resection, KRAS mutation, TP53 mutations and so forth can also be predictive of various responses to therapy. So here's one example of a way to assess for microsatellite instability. This is showing you DNA samples from both first normal tissue here with a couple of fragment size evaluations looking at here. Whereas in a patient who has microsatellite instability, we see a wider array of fragment sizes based on the number of peaks and their relative amplitude. Now, that's a little bit more complicated way to detect this tendency, and so immunohistochemistry has been widely employed to monitor for the presence or absence of many of these proteins that would therefore be otherwise encoded by intact systems. So here's an example of MLH1 immunohistochemistry. We can see that in the normal tissues, this is being expressed, whereas here in our tumor cells, we do not see expression of this marker. Likewise, we see that here in this even better differentiated tumor, where the tumor cells lose expression of the marker, which is otherwise expressed in normal tissues. So there are a variety of ways of interpreting these mismatch repair defects based on the use of the four markers, MLH1, MSH2, MSH6, and PMS2. And this is a fairly standard interpretation derived from the CAP checklist. If there's no loss of expression, it's considered microsatellite satellite high, low probability. Whereas if you've lost expression of MLH1 and 2, that may indicate epigenetic or BRAF mutation to account for the loss of that. If you've lost both MSH2 and MSH6, that's most commonly seen in the setting of germline loss, Lynch syndrome, and therefore sequencing or further evaluation is indicated in there. Similarly, with MSH6 loss or isolated loss of PMS2, those tend to be more frequently associated with Lynch syndrome, and therefore germline testing to evaluate for these can be indicated. Now, which patients should be tested for microsatellite instability? Well, traditionally, historically, there were criteria developed to attempt to identify patients, beginning perhaps by looking at incidence of colon cancers in younger patients, or evidence of other associated tumors such as endometrial stomach, et cetera, or patients who had a particular histology in a particular age group, or patients who had relatives with one of these tumors, and so forth. These criteria were better than no criteria, but they were not perfect in identifying all patients. So here's an example of numerous tumor-infiltrating lymphocytes. This was a histologic feature that could have been associated with the presence of microsatellite instability. And a whole listing, actually, of relative pathologic and microscopic features was developed with varying degrees of predictive value. As you can see, medullary type was the highest predictive value, but even some things such as a cribriform pattern had a small predictive value in terms of identification. But the long and short of it is that this methodology was flawed. It was not particularly fruitful in catching all the patients that one would hope to be able to catch. The Amsterdam Criteria attempt to go a step further and look for some further ways of going after these things. But I would say, by and large, these criteria have tended to be supplanted by more universal testing. This, for example, gives you an idea that the Amsterdam Criteria could detect and screen out various patients. But if you look more candidly at what is being done today, I think that all newly diagnosed colorectal carcinoma patients, at least in our institution, I think a majority of other similar institutions today, would have immunohistochemistry as their screening criteria. Where that's intact, then questioning the family history may be important, and then if there's something in the family history, then they might go to DNA-based testing or germline testing to potentially identify further evaluation using the MSI testing modality. In patients who were found to have MLH1 deficiency, BRAF testing was the next stage. If it's present, then that again indicates MLH sporadic methylation. If it's not present, then they would do methylation testing to potentially detect Lynch syndrome. And for the MSH2, 6, and PMS2 patients, those patients went to germline testing to detect Lynch syndrome. If we think about the molecular pathways that are involved here and some of the potential treatments, this really is related to the epidermal growth factor receptor. And in these patients where there are blockages or mutations or constitutive activation in these situations, the use of anti-EGFR treatments is not going to impact it. So patients with, constitutive active that have got BRAF or KRAS mutations that are already turning on this MAPK pathway, they're not going to benefit from any high-priced anti-EGFR agent. And similarly for certain other mutations as well. And that's the rationale behind some of these testing methodologies as well. Here's an example of one of the ways that KRAS mutation can be done by Sanger sequencing, although I think today most people would be using next generation sequencing for this analysis. But here you can see the implementation or the induction of an A in place of the expected wild type G here in this scenario. And seen on a graphic way, here's the wild type. You have the G for the A for G substitution, leading to a change in the amino acid in the protein, and therefore a mutation is involved. So where are we then with molecular testing? I think the answers to this question are evolving and probably will continue to do so as more individualized treatments become available. But essentially, testing should be done when it will make a difference in treatment. Certainly now for certain stage 2 and 3 tumors, as well as some stage 4 tumors, knowledge of these biomarkers is critical to determining which treatments they may be eligible for and likely to respond to. Similarly, if they've exhausted first-line treatment, then some additional molecular testing, maybe more extensive mutation analysis to look for targetable agents can be considered. Or if it's going to make a difference in the follow-up of other family members and their screening for colorectal cancers, then that's certainly valuable test data. If the result is going to predict a difference in treatment response, we've talked about that. Certainly MSI, KRAS, and potentially P53 testing may indicate that. And then finally, these things are not without costs, and so taking on the responsibility to do this when there is a viable and sustainable financial model to support the testing is also important. So that's a very quick run through on some of the issues surrounding colorectal carcinoma, its classification and identification, and germline and various other molecular biomarker testing that may be considered. If you have questions, please don't hesitate to reach out. We're always eager for feedback. if this is helpful, and if there are other topics you'd like to see us cover in the future. We hope that you'll like the video and comment below. And of course, we always welcome you to subscribe so that you don't miss future videos that we post. Thanks again for joining us, and until next time, have a good day.